Question 1. Radiation treatment planning and techniques. A patient with early-stage lung cancer is being considered for stereotactic body radiation therapy (SRT). Which of the following considerations is most critical in determining if SRT is appropriate for this patient? A. The patient's age and smoking history. B. Tumor location relative to organs at risk scores. C. The patient's Karnofsky performance score KPS. D. The size of the tumor alone. Answer B. Tumor location relative to organs at risk scores. Explanation. Stereotactic body radiation therapy (SRT) is a high-dose radiation therapy technique that delivers precise doses to small tumors with minimal exposure to surrounding tissues. While patient factors such as age and performance status (KPS) play a role in treatment planning, the most critical factor in SRT eligibility is tumor location relative to near organs at risk scores, such as the esophagus, spinal cord, heart, and major blood vessels. Option was incorrect. While smoking history is relevant for lung cancer prognosis, it does not directly determine SRT eligibility. Option C incorrect. Karnofsky performance score (APS) helps assess whether a patient can tolerate treatment, but it is not the primary factor in deciding SRT feasibility. Option D incorrect. Tumor size is a consideration, but SRT is typically used for tumors 5 centimeters. However, proximity to ORs is more critical than size alone. Relevant guidelines or SRT guidelines recommend dose constraints for ORs such as spinal cord 18 Gi in 3 fractions and esophagus 27 Gi in 3 fractions. Radiation Oncology Accreditation standards require detailed evaluation of organ constraints and motion management for SRT. Question 2. Radiation toxicity and side effects. Scenario-based. Dr. Patel, a radiation oncologist, is treating a patient with prostate cancer using intensity-modulated radiation therapy. After completing treatment, the patient reports persistent rectal bleeding and increased stool frequency. Dr. Patel suspects radiation proctitis. What is the best initial management approach in this case? A. Immediately initiate hyperbaric oxygen therapy. B. Recommend dietary changes, stool softeners, and symptomatic management. C. Perform an emergency colonoscopy and biopsy. D. Administer systemic corticosteroids to reduce inflammation. Answer B. Recommend dietary changes, stool softeners, and symptomatic management. Explanation. Radiation proctitis is a common late toxicity of pelvic radiation therapy, often presenting with rectal bleeding, urgency, and changes in bowel habits. The best initial management includes dietary modifications, low-fiber diet to reduce irritation, stool softeners to minimize mechanical trauma, anti-inflammatory suppositories e.g. mesalamine or hydrocortisone. Option quote incorrect. Hyperbaric oxygen therapy may help in severe chronic radiation proctitis, but it is not the first-line approach. Option C incorrect. A colonoscopy is not required immediately unless there are red flag symptoms e.g. large volume bleeding, obstruction. Option D incorrect. Systemic corticosteroids are not recommended for radiation proctitis because the inflammation is localized and not systemic. Relevant guidelines. ASTRO and NCN guidelines for pelvic radiation toxicity recommend supportive management as first-line therapy. Radiation Oncology Accreditation standards emphasize patient follow-up and toxicity management as part of quality assurance. Question 3. Radiation protection and safety standards. A radiation oncology department is reviewing its radiation protection program to ensure compliance with ALARA as low as reasonably achievable principles. Which of the following measures best aligns with ALARA principles to minimize staff radiation exposure? A. Increasing the workload of high-dose procedures to improve treatment efficiency. B. Conducting annual radiation monitoring instead of monthly dosimeter checks. C. Using remote afterloading for high-dose rate HDR brachytherapy procedures. D. Eliminating shielding barriers to allow better patient access during treatment. Answer C. Using remote afterloading for high-dose HDR brachytherapy procedures. Explanation. The ALARA principle in radiation oncology emphasizes 3 key factors to minimize radiation exposure: time, reducing exposure duration; distance, maximizing distance from the radiation source; shielding, using protective barriers. Remote afterloading in HDR brachytherapy is an effective ALARA strategy because it allows the source to be placed only after personnel have exited the treatment room, minimizing exposure. It ensures precise source positioning, improving safety and treatment accuracy. Option was incorrect. Increasing workload may improve efficiency but raises overall radiation exposure risk for staff. Option B, incorrect. Monthly dosimeter checks are a standard safety measure. Reducing monitoring frequency increases the risk of undetected exposure. Option D, incorrect. Eliminating shielding violates NRC and ACA radiation protection regulations, putting staff at unnecessary risk. Relevant guidelines: NRC Nuclear Regulatory Commission Regulations 10 CFR 20 mandate time, distance and shielding principles for radiation safety. ACA and OPAM radiation protection guidelines require staff to use personal dosimeters and shielding for radiation safety compliance. Question 4. Topic: Radiation physics and dosimetry. A radiation oncology facility is conducting a quality assurance review of its treatment planning system (TPS). The physicist notices that the Monte Carlo simulation results differ slightly from the measurements obtained from ion chamber dosimetry for high-energy photon beams. The discrepancy is about 3%, and the physicist is concerned about whether this falls within acceptable limits. Which of the following is the most appropriate action to take in response to this finding? A. Adjust the beam calibration in the treatment planning system to match the ion chamber measurements. B. Investigate the source of the discrepancy by verifying beam modeling parameters and performing additional dosimetric validation. C. Disregard the discrepancy since a 3% variation is within the general tolerances for radiation dose measurements. D. Replace the Monte Carlo simulation with a more traditional calculation algorithm as pencil beam or analytical anisotropic algorithm. Answer B. Investigate the source of the discrepancy by verifying beam modeling parameters and performing additional dosimetric validation. Explanation: Monte Carlo simulations are considered one of the most accurate dose calculation methods in radiation oncology, but they require rigorous validation. A 3% discrepancy may fall within some institutions' acceptable limits, but it should still be investigated. The OPAM Task 53 recommends that discrepancies between TPS calculations and measurements should be analyzed for potential systematic errors. Beam modeling parameters, including source size, scatter models, and energy spectrum, should be reviewed. A. Incorrect. Adjusting beam calibration arbitrarily may introduce additional errors without understanding the root cause. C. Incorrect. While 3% may be within tolerance, best practice is to identify and correct any systematic discrepancies. D. Incorrect. While traditional algorithms are useful, Monte Carlo methods are typically more accurate, and the issue is likely related to model validation rather than the algorithm itself. Question 5. Topic: Radiation protection and safety standards. A radiation oncology center recently installed a new linear accelerator, LINAC, and is in the process of commissioning it for clinical use. During shielding verification tests, a physicist detects slightly elevated scattered radiation levels outside a secondary barrier, though still within regulatory limits. What should the facility do to ensure compliance with safety standards and ALAR principles? A. Proceed with patient treatment since radiation levels are within the regulatory limits. B. Modify the shielding or implement additional protective measures to further reduce exposure to staff and the public. C. Increase the workload limit for the LINAC to compensate for shielding deficiencies. D. Reduce the fractionation schedule to limit radiation exposure to the surrounding areas. Answer B. Modify the shielding or implement additional protective measures to further reduce exposure to staff and the public. Explanation: even though the measured scattered radiation is within regulatory limits, the ALARA, as low as reasonably achievable, principle mandates that radiation exposure should be minimized whenever possible. According to SRP Report No. 151, additional shielding, re-evaluating barrier design, or implement administrative controls such as access restrictions are appropriate measures. A. Incorrect. Meeting regulatory limits does not necessarily mean the exposure is optimized. C. Incorrect. Increasing the LINAC workload would exacerbate the problem rather than mitigate it. D. Incorrect. Altering fractionation schedules does not address the underlying shielding concern. Question 6. Scenario-based. Topic: Clinical radiation oncology. Re-radiation considerations. Dr. Patel is treating 65-year-old patient with recurrent head and neck cancer who previously received full course of radiation therapy, 70 GI, to the same region 5 years ago. The patient's tumor board recommends re-radiation due to limited surgical options. Which of the following considerations is most critical in re-radiation for this patient? A. Use lower total dose e.g. 4550 GI with advanced techniques such as IMiD or proton therapy to minimize normal tissue toxicity. B. Deliver second full dose of 70 GI as tumor recurrence indicates need for aggressive treatment. C. Use conventional fractionation, 2 Gi per fraction, to mirror the previous radiation course and maximize tumor control. D. Avoid re-irradiation altogether, as radiation to 70 Gi makes further radiation unsafe. Answer A. Use it. Lower total dose e.g. 4550 Gi with advanced techniques such as IMiT or proton therapy to minimize normal tissue toxicity. Explanation: re-irradiation in the head and neck region requires extreme caution due to the high risk of late toxicities including necrosis, fibrosis, and vascular damage. Studies and ASTRO guidelines suggest a lower dose e.g. 4550 Gi with formal techniques like IMiT or proton therapy to achieve tumor control while minimizing toxicity. B. Incorrect. Repeating a full 70 Gi course would exceed tissue tolerance and likely cause severe complications. C. Incorrect. Conventional fractionation may not be optimal in re-irradiation cases where hyperfractionation can reduce toxicity. D. Incorrect. While re-irradiation carries risks, careful planning with modern techniques make feasible in selected cases. Question 7. Topic: Imaging in radiation oncology. A radiation oncologist is planning stereotactic body radiation therapy (SRT) for a patient with a solitary lung metastases. To ensure accurate targeting, the team is considering different image registration techniques. Which imaging method provides the most accurate target localization for SRT? A. PET-AT fusion with diagnostic CT. B. Forward CT with respiratory gating. C. Standard CT simulation with no motion management. D. MRI fusion alone with the E. Answer B. Forward CT with respiratory gating. Explanation: Forward CT with respiratory gating is essential for SRT in lung tumors to account for tumor motion due to breathing. The Open Task Group 76 recommends Forward ET as the standard for motion assessment in thoracic radiation therapy. A. Incorrect. PET-ET is useful for tumor delineation but lacks detailed motion tracking. C. Incorrect. Standard CT alone does not account for tumor motion, increasing the risk of geographical miss. D. Incorrect. MRI provides excellent soft tissue contrast but lacks accurate motion assessment for lung tumors. Question 8. Topic: Brachytherapy physics and applications in high-dose HDR. Brachytherapy for cervical cancer. What is the primary reason for using a tandem and ovoid TO applicator system rather than external beam therapy alone? A. It allows for higher doses to the tumor while sparing surrounding normal tissues. B. It delivers a uniform dose throughout the entire pelvis. C. It has a low risk of rectal and bladder toxicity compared to D. It eliminates the need for external beam radiation therapy. Answer A. It allows for higher doses to the tumor while sparing surrounding normal tissues. Explanation: HDR brachytherapy concentrates dose within the cervix and reduces exposure to the bladder and rectum following the ICRU Report 89 guidelines. B. Incorrect. Brachytherapy does not provide uniform pelvic dosing. C. Incorrect. HDR brachytherapy still carries rectal and bladder toxicity risks. D. Incorrect. EBIT is typically in combination with brachytherapy. Question 9. Topic: Quality assurance in radiation therapy. A radiation oncology department is implementing a new intensity modulated radiation therapy (IMiT) program. The medical physicist is responsible for ensuring accurate dose delivery through a rigorous quality assurance (CAR) program. Which of the following CAR procedures is most essential before initiating clinical IMiT treatments? A. Patient-specific CAR, including gamma index analysis, effluent maps, and independent dose verification. B. Quarterly recalibration of the linear accelerator's output using ion chamber measurements. C. Annual review of all treatment planning system (TPS) parameters and B. Modeling data. D. Performing daily output constancy checks using standard water phantom. Answer A. Patient-specific CAR, including gamma index analysis of fluence maps and independent dose verification. Explanation: IMiT requires precise dose delivery, so patient-specific CAR is crucial to verify treatment plan accuracy. The UP TG119 and TG218 recommend gamma index analysis e.g. 3% 3 mm criteria and independent dose verification to ensure safety. B. Incorrect. Quarterly recalibration is important but not specific to IMiT CAR. C. Incorrect. Annual TPS review is necessary but does not replace patient-specific CAR. D. Incorrect. Daily output checks ensure machine consistency but do not verify IMiT plan accuracy. Question 10. Topic: Radiobiology and fractionation. In a patient with a single 2.5 cm brain metastases is scheduled for stereotactic radiosurgery SRS Ewing. A single fraction dose of 20 Gi. The treating physician is concerned about normal brain tissue toxicity. Which of the following is the most appropriate strategy to reduce toxicity while maintaining tumor control? A. Deliver the dose over 3 to 5 fractions instead of a single fraction. B. Reduce the dose to 15 Gi in a single fraction. C. Use a low-energy photon beam to minimize dose fall-off. D. Avoid SRS and treat with whole-brain radiation therapy instead. Answer: A. Deliver the dose over 3 to 5 fractions instead of a single fraction. Explanation: hypofractionation 3-5 fractions reduces toxicity to surrounding brain tissue while maintaining tumor control. Per ASTRO guidelines, SRE fractionate SRS is particularly useful for lesions 2 cm. B. Incorrect. Reducing dose may compromise local control. C. Incorrect. Photon energy does not significantly impose fall-off in SRS. D. Incorrect. Reserved for multiple metastases. Arrays preferred for solitary lesions. Question 11. Topic: Proton therapy in head and neck cancer. A 58-year-old patient with nasopharyngeal cancer is being evaluated for radiation therapy. Given the tumor's proximity to critical structures, proton therapy is being considered. What is the primary dosimetric advantage of proton therapy in this case? A. Superior dose homogeneity across all target volumes. B. Reduction in dose to critical structures due to the Bragg peak effect. C. Low cost and increased accessibility compared to IM. D. More effective tumor control compared to conventional photon therapy. Answer: B. Reduction in dose to critical structures due to the Bragg peak effect. Explanation: proton therapy delivers dose with high precision due to the Bragg peak, reducing exposure to nearby organs at risk, such as the brainstem, optic nerves, and salivary glands. A. Incorrect. Proton dose homogeneity can be challenging due to range uncertainties. C. Incorrect. Proton therapy is more expensive and less widely available. D. Incorrect. Tumor control is similar between proton and IMiT. The advantage is reduced normal tissue toxicity. Question 12. Topic: Brachytherapy and prostate cancer. A 72-year-old patient with low-risk prostate cancer is considering brachytherapy as definitive treatment. The radiation oncologist must decide between low-dose rate LDR and high-dose rate HDR brachytherapy. Which of the following is an advantage of HDR brachytherapy over LDR? A. Greater radiobiological effectiveness due to high dose per fraction. B. Low requirement for specialized equipment. C. Low risk of acute toxicity compared to LDR. D. More uniform dose distribution to the entire prostate gland. Answer: 8. Greater radiobiological effectiveness due to high dose per fraction. Explanation: HDR brachytherapy delivers a higher dose per fraction, increasing the tumor control probability TCP while minimizing exposure to normal tissue. B. Incorrect. HDR requires specialized afterloading equipment. C. Incorrect. HDR may have a slightly higher risk of acute toxicity than LDR. D. Incorrect. LDR provide continuous dose over time, potentially leading to more uniform distribution. Question 13. Topic: Electron therapy in skin cancer. A patient with a 3 cm squamous cell carcinoma on the scalp is treated with electron beam therapy. The radiation oncologist must determine the appropriate energy selection. Which of the following is the best choice for treatment? A. 6 MeV electrons to provide adequate surface dose while minimizing deep penetration. B. 15 MeV electrons to ensure complete tumor coverage. C. 18 MeV electrons to account for tissue heterogeneity. D. Use of 6 MeV photons for better tissue penetration. Answer: A. 6 MeV electrons to provide adequate surface dose while minimizing deep penetration. Explanation: electrons provide high surface dose and have limited penetration. A 6 MeV beam is appropriate for superficial lesions up to 1.5 cm deep, while higher energies penetrate deeper. B and C. Incorrect. 1518 MeV electrons would deposit excessive dose beyond the tumor. D. Incorrect. Photons penetrate deeper and are not ideal for superficial skin cancer. Question 14. Topic: Stereotactic body radiation therapy SRT for liver tumors. A patient with a solitary liver metastases 3 cm and child pug. A cirrhosis is referred for SERT. The radiation oncologist must choose an appropriate dose fractionation scheme. Which of the following is the optimal approach? A. 4-5 50 Gi in 3-5 fractions with image guidance. B. 30 Gi in 10 fractions to minimize toxicity. C. 70 Gi in 35 fractions to maximize local control. D. 20 Gi in a single fraction for rapid treatment. Answer A. 4550 Gi in 3-5 fractions with image guidance. Explanation: SRT for liver metastasis typically uses 4550 Gi in 3-5 fractions, balancing tumor control with liver toxicity. B. Incorrect. 30 Gi in 10 fractions is suboptimal for SRT. C. Incorrect. 70 Gi in conventional fractions increases treatment time and toxicity. D. Incorrect. Single fraction SR is not standard for liver tumors due to toxicity concerns. Question 15. Topic: Radiation toxicity in prostate cancer. A patient receiving definitive IMiD for prostate cancer reports new onset hematuria and urinary frequency at week 5 of treatment. What is the most likely cause? A. Acute radiation cystitis due to bladder wall irritation. B. Tumor progression causing urethral obstruction. C. Bladder infection unrelated to radiation. D. Radiation-induced renal failure. Answer A. Acute radiation cystitis due to bladder wall irritation. Explanation: Radiation cystitis is a common acute toxicity of pelvic irradiation, causing hematuria, frequency and urgency. B. Incorrect. Tumor progression is unlikely mid-treatment. C. Incorrect. While infection is possible, radiation cystitis is more likely. D. Incorrect. Radiation-induced renal failure is rare at standard doses. Question 16. Topic: Whole breast irradiation techniques. Which of the following is the primary benefit of hypofractionated whole breast irradiation? 40 Gi in 15 fractions over conventional fractionation, 50 Gi in 25 fractions. A. Equivalent tumor control with reduced treatment duration. B. Low risk of skin toxicity compared to standard fractionation. C. Reduced risk of distant metastasis. D. Improved overall survival compared to conventional fractionation. Answer A. Equivalent tumor control with reduced treatment duration. Explanation: Studies like the START trial show hypofractionation is non-inferior to conventional RT with similar local control and shorter treatment duration. B. Incorrect. Skin toxicity is similar or slightly higher. C. Incorrect. Fractionation does not affect distant metastasis. D. Incorrect. Survival is comparable between regimens. Question 17. Topic: Radiation safety in pregnant patients. A 32-year-old pregnant woman requires palliative radiation therapy for a spinal metastases. Which of the following is the best strategy to minimize fetal exposure? A. Use photon beams with appropriate shielding. B. Use electron therapy instead of photons. C. Avoid radiation completely until after pregnancy. D. Deliver the treatment under general anesthesia to prevent fetal movement. Answer A. Use photon beams with appropriate shielding. Explanation: Proper lead shielding and field design minimize fetal dose, allowing safe treatment if necessary. B. Incorrect. Electrons do not penetrate deep enough for spinal metastases. C. Incorrect. Delaying treatment could worsen the patient's prognosis. D. Incorrect. General anesthesia does not reduce fetal dose. Question 18. Topic: Reirradiation in head and neck cancer. A 58-year-old male with a history of stage-own oropharyngeal cancer treated with definitive IMiD, 70 Gi in 35 fractions, 5 years ago presents with a new biopsy-confirmed recurrence in the same region. The tumor board recommends reirradiation. What is the most significant concern when considering reirradiation? A. Increased risk of severe late toxicity, including osteoradionecrosis and carotid blowout. B. Suboptimal tumor control due to prior radiation resistance. C. Need for high doses to overcome radioresistance. D. Inability to use intensity-modulated radiation therapy IMiDs. Answer A. Increased risk of severe late toxicity, including osteoradionecrosis and carotid blowout. Explanation: Reirradiation carries significant risks, including osteoradionecrosis or carotid blowout and fibrosis. Dose constraints must be carefully considered, and brachytherapy or proton therapy may help reduce normal tissue toxicity. B. Incorrect. Prior radiation does not inherently cause radioresistance. C. Incorrect. High doses increase toxicity without a guarantee of improved outcomes. D. Incorrect. IMiD is often used for reirradiation to spare normal tissues. Question 19. Topic: Stereotactic body radiation therapy SRT for lung cancer. A 72-year-old patient with stage I non-small cell lung cancer SLC and severe COPT is deemed inoperable and referred for SRT. What is the most appropriate CRT dose fractionation? A. 54 Gi in 3 fractions. B. 50 Gi in 5 fractions. C. 45 Gi in 15 fractions. D. 30 Gi in 10 fractions. Answer: B. 50 Gi in 5 fractions. Explanation: SRT for inoperable early-stage SLC Pipica uses 4854 Gi in 3-5 fractions. A 5-fraction regimen reduces toxicity, especially in patients with compromised lung function. A. Incorrect. 54 Gi in 3 fractions is highly effective but increases lung toxicity in patients with poor pulmonary reserve. C. And D. Incorrect. Conventional fractionation, 10 fractions, does not provide the high bed required for tumor control. Question 20. Topic: Radiation dose constraints in esophageal cancer. A patient with locally advanced esophageal cancer is receiving definitive chemoradiation, 50.4 Gi 28 fractions. The radiation oncologist must ensure spinal cord dose constraints are met. What is the most appropriate spinal cord dose constraint? A. Mach equals 45 Gi. B. Mach equals 50 Gi. C. Mach equals 54 Gi. D. Minus equals 20 Gi. Answer: 8 Mach equals 45 Gi. Explanation: for conventional fractionation, the spinal cord should receive 45 Gi, significantly increase the risk of radiation myelopathy. D. Incorrect. The mean dose is less relevant than the maximum dose for the spinal cord. Question 21. Topic: Brain metastasis and hippocampal split. A 55-year-old patient with multiple brain metastases, 7 lesions, has ERS of 90 and is planned for whole brain radiation. Or which of the following approaches best preserves cognitive function? A. Hippocampal SPED. B. Memantine. B. STADA-B without hippocampal avoidance. C. Stereotactic radiosurgery SRS to all lesions. D. Prophylactic cranial irradiation EC. Answer: A. Hippocampal SPED. B. Memantine. Explanation: hippocampal SPED-B reduces radiation dose to memory-associated regions, preserving cognitive function. Memantine further reduces neurocognitive decline. B. Incorrect. STADA-B increases the risk of cognitive impairment. C. Incorrect. RS is preferable for 4 lesions but may not be ideal for multiple lesions. D. Incorrect. PCI used in small cell cancer SLC, not in metastatic disease. Question 22. Topic: Reirradiation in rectal cancer. A patient with recurrent rectal cancer previously treated with 50.4 Gi in the pelvis presents for salvage radiation therapy. What is the most significant concern in this case? A. Increased risk of radiation-induced enteritis and bowel perforation. B. Radioresistance of recurrent tumors. C. Need for higher radiation doses. D. Lack of effective systemic therapy options. Answer: A. Increased risk of radiation-induced enteritis and bowel perforation. Explanation: pelvic reirradiation increases the risk of severe late toxicity, including bowel necrosis and fibrosis. Careful dose constraints and proton therapy may be considered. Question 23. Topic: Proton therapy for pediatric tumors. Which of the following is the primary advantage of proton therapy in pediatric patients with brain tumors? A. Lower integral dose to normal tissues, reducing long-term toxicity. B. Higher biological effectiveness compared to photons. C. Shorter treatment duration compared to. D. Better tumor control than standard photon therapy. Answer: A. Lower integral dose to normal tissues, reducing long-term toxicity. Explanation: proton therapy reduces dose to normal tissues, minimizing growth impairment, cognitive deficits, and secondary malignancies. B. Incorrect. Protons have a similar relative biological effectiveness, RBE, to photons, RBE 1.1. C. Incorrect. Treatment duration is similar to tumor. D. Incorrect. Proton therapy does not tumor control but reduces side effects. Question 24. Topic: Radiation necrosis versus tumor progression. A patient with glioblastoma previously treated with 60 Gi in 30 fractions plus temozolomide presents with new enhancing lesions and MRI 6 months later. Which imaging modality is most useful to differentiate radiation necrosis from tumor progression? A. Mr. Spectroscopy and perfusion MRI. ET with contrast. C. PET scan using FDG. D. Play MRI without contrast. Answer: A. Mr. Spectroscopy and perfusion MRI. Explanation: Mr. Spectroscopy and perfusion MRI help distinguish tumor progression, high metabolic activity from radiation necrosis, low perfusion, high lactate. B. Incorrect. CT has poor soft tissue contrast for brain lesions. C. Incorrect. F to G. PET is unreliable due to high glucose uptake in normal brain tissue. D. Incorrect. Plain MRI lacks functional capabilities. Question 25, topic SRT dose constraints for spinal metastases. A patient with a single spinal metastases from renal cell carcinoma is referred for stereotactic body radiation therapy SRT. The goal is pain relief and local control while avoiding radiation myelopathy. What is the recommended maximum spinal cord dose for single fraction SRT in spinal metastases? It equals 14 di. E equals 18 gi, E 24 gi, E 30 gi. Answer: E equals 14 gi. Explanation: for single fraction SRT, G 1624 gi in one fraction, the spinal cord should receive 14 gi, increase the risk of delayed radiation-induced myelopathy. C and D incorrect. Spinal cord doses above 18 gi have high probability of causing permanent neurological damage. Bulb for multifraction SRT, G 30 gi in 5 fractions, moral. Constraint of EMA called 22 gi is used. Question 26. Topic: whole brain radiation of birth versus SSET. A 62-year-old patient with 3 brain metastases from non-small cell lung cancer. SL, the largest LEA equals 0.5 centimeters. Presence with no significant neurological symptoms. The oncologist must decide between whole brain radiation or stereotactic radiosurgery (SRS). Which treatment approach provides the best balance of tumor control and cognitive function preservation? A. SRS alone, B. Alabor plus memantine. D. Prophylactic cranial irradiation (ECIA). Answer: A. SRS alone. Explanation: for forebrain metastasis, SRS alone is preferred to maximize local control and preserve cognitive function. B. Accreditation increases the risk of neurocognitive decline. C. Accreditation plus memantine helps but still causes more cognitive toxicity than SRS. D. Incorrect. PCI is not used for metastatic S, also only in limited stage small cell lung cancer (SSA). Question 27. Topic: radiation-induced myelopathy. A patient treated with IMiT to the cervical spine for metastatic disease develops progressive weakness, sensory loss, and spasticity 8 months later. MRI shows T hyperintensity without enhancement in the spinal cord. What is the most likely diagnosis? A. Radiation-induced myelopathy. B. Tumor progression. C. Infectious myelitis. D. Multiple sclerosis (MS) relapse. Answer: A. Radiation-induced myelopathy. Explanation: radiation myelopathy presents months to years after radiation, with progressive weakness and sensory changes, often with T hyperintensity without contrast. Enhancement. B. Incorrect. Tumor progression would likely show enhancement and mass effect. C. Incorrect. Infectious myelitis usually presents acutely with enhancement. D. Incorrect. MS plaques typically show paraventricular distribution. Episodic relapse. Bulb prevention. Maintain spinal cord democal 45 gi conventional fractionation to 14 yet. Question 28. Topic: radiation treatment for unresectable pancreatic cancer. A 68-year-old patient with locally advanced pancreatic cancer is planned for definitive chemoradiation with IMiT, intensity modulated radiation therapy. Which of the following dose constraints is most critical for minimizing gastrointestinal toxicity? A. Mean LIAS equals 28 gi. B. Dmax to small ball equals 50 gi. C. In kidneys equals 15 gi. D. Spinal cord max equals 45 gi. Answer: B. Dmax to small bowel equals 50 gi. Explanation: the small bowel is the most critical organ at risk or in pancreatic radiation therapy. Doses above 50 gi increase the risk of severe enteritis, obstruction, or perforation. A. Incorrect. Mean liver dose is relevant but less critical than small bowel constraints. C. Incorrect. Kidney constraints are important but less of an acute concern. D. Incorrect. The spinal cord constraint is important, but the primary concern in pancreatic cancer is gastrointestinal toxicity. Question 29. Topic: reirradiation for head and neck cancer. A 60-year-old male with recurrent oropharyngeal cancer is being considered for reirradiation after receiving 70 gi 5 years ago. What is the greatest risk associated with reirradiation in this scenario? A. Carotid blowout syndrome. B. Tumor radioresistance. C. Need for higher radiation dose. D. Systemic toxicity from chemotherapy. Answer 8. Carotid blowout syndrome. Explanation: radiation in head and neck cancer significantly increases the risk of major vascular injury, carotid blowout, especially when cumulative doses exceed 100,120 Gi. B. Incorrect. Tumor radioresistance is not a primary concern. C. Incorrect. Higher doses increase toxicity without guaranteed benefit. D. Incorrect. Chemotherapy toxicity is a concern, not the primary risk. Bulb strategies to reduce risk: use IMiD or proton therapy, limit carotid dose, monitor with imaging. Question 30. Topic: SRS for brain metastases. Dose constraints. A patient with a single 2 cm brain metastases is planned for stereotactic radiosurgery SRS. What is the most appropriate single fracture SRS dose while maintaining an acceptable risk of toxicity? A. 12 Gi. B. 18 Gi. C. 24 Gi. D. 30 Gi. Answer: B. 18 Gi. Explanation: for SRS of brain metastases, 1.6-2.4 Gi is used for single lesions depending on size and location. 18 Gi is appropriate for a 2 cm lesion, balancing tumor control and risk of radiation necrosis. A. Incorrect. 12 Gi is too low for effective tumor control. C and D. Incorrect. Doses above 24 Gi increase the risk of radiation necrosis. Bold key dose guidelines for single fraction SRS: 3 cm, 1.2-1.6 Gi.